Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by the Laborers International Union of North America. I'm Leslie Rattan and really pleased to be moderating our series, which was developed for individuals that have sustained concussions, their caregivers, and healthcare providers. And if you haven't been with us before, the sessions focus on various aspects of concussion and typically start with an expert speaker who we hear from. And that sort of takes up the first half of our webinar. And the second half is a time where you can get your questions answered. The sessions, again, for those that aren't aware, recur every other week. And from 6 to 7 p.m. on Tuesday evenings. And just so that you know as well, all of our presentations are archived, and you can actually access those after the fact on the Canadian Concussion Center's website. And thank you to Christian, who has just put the link in the chat. So if you're ever wanting to go back and check any of those out, you can do that. I'd also like to just begin by acknowledging the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. And with that, just a couple of housekeeping items. If you do have a question, if you sort of just move your cursor, you'll see that at the bottom of the screen, there's a Q&A icon. So if you have any questions for our speaker tonight, we ask that you enter your questions there. If you're having any technical difficulties, please enter those into the chat and Christian can give you a hand. And just before we get to our speaker, we're going to run a short poll. We always do this just to get a sense of who is in the audience. So I'll just wait for that to pop up. There we go. Okay. So I'm really pleased to welcome back Dr. Claire Sandoe, who's going to be presenting headache and concussion tonight. Dr. Sandoe is an assistant professor of medicine, neurology at the University of Toronto and a headache neurologist at the Women's College Hospital Centre for Headache, where she directs the citywide Headache Medicine Fellowship. She serves on the boards of the Canadian Headache Society and the American Migraine Foundation, the education committees of the International Headache Society and the American Headache Society, and is co-chair of the Canadian Headache Society National Neurology Resident Headache Course, as well as the American Headache Society's Mastering Migraine Therapies program. She is co-chair of the American Migraine Foundation editorial board, and she's passionate about improving awareness, understanding, and treatment options for people living with migraine and other headache disorders, and hopes to help work towards a more migraine-friendly world. And with that, I'm going to turn it over to Dr. Sandoe.
Thank you for that lovely introduction, Dr. Rattan. I'm going to share my screen, hopefully. I believe that this should be visible. Please let me know if not. So I'm looking forward to first talking and then hopefully having a nice discussion tonight about headache after concussion. And I have a couple of disclosures just to mention before we start, including my work for the American Migraine Foundation, which involves a lot of more patient-targeted education. And so anybody who's interested in looking at some of our educational materials, please do so. We have a great website. So objectives for us tonight are that over the next half hour or so, you'll be able to outline the diagnostic criteria for acute and persistent post-traumatic headache, which we'll abbreviate as PTH, distinguish the different ways that this can look, the phenotypes, and then think about how to approach treatment from a multimodal perspective. And so we're going to start with a patient story that may sound or feel familiar. So Ryan, who is 21 and is second-year pre-med student who has really not had much happen health-wise, just had tonsils out, not taking meds, does have some family members who live with migraine, mom and sister, and had a grandmother with dementia, and tells you that while snowboarding over the Christmas holidays last year, he fell, but kept going, didn't really think very much of it. But later the same day, started to notice there was a mild headache, and he had these sparkly, weird things in vision that were there for about 10 minutes. And when he went back to school soon after that, the headaches got much worse. The screens and trying to concentrate were making it much worse, and he was worried that he would not be able to become a doctor after all. And so I imagine that this may sound or feel familiar in terms of something that can happen to you, your family members, your patients. So why do I get to talk about this? Why should we care about headache in the context of concussion? Is it just a headache? So this is a really common piece of the experience for people who've had concussion. Somewhere between 25 and 90% of people with concussion have headache as a component of their symptoms at some point. So this is, depending on the study, more patients than not will have some form of headache. And this impacts something like 4.7% of men over the lifetime and 2.4% of women over the lifetime. So this is a lot of people. And it can be extremely disabling. So it can persist and stay there for months to years. And again, it's tough to have data in this area, but there's somewhere between 15 and 75% of people who have a headache continue to have that headache months to years later. So again, this can be quite a lot. And 20% of those who do have headaches still have it 4 years later. So again, this is a lot of people. That does mean that there are 80% of people who don't, but this is a significant impact. So some common questions that I get asked or that people may wonder about headache in the context of concussion. So I fell down, but I didn't hit my head. Can this still be concussion related, the headache? Or I didn't lose consciousness, so it can't be related to concussion, can it? Or the other one that I sometimes get asked, I had a head injury as a child. Does that mean that these headaches I'm having now are caused by the concussion that I had back then? So we're just going to talk through all of the answers to those kinds of questions. So defining post-traumatic headache, or PTH, we use in the headache world these criteria established by the International Headache Society, the International Classification of Headache Disorders, or ICHD-3. And so they have this chapter 5.1 and 5.2, headache attributed to a traumatic injury to the head. And these are the sort of big picture criteria. They have lots of subcategories depending on how serious the head injury was. But in general, you have any headache in the context of a traumatic injury to the head. You'll note that it doesn't actually say there has to be a direct impact to the head. The headache should have developed within 7 days of either the injury itself, coming back to consciousness after, or stopping medications that might have been keeping you from knowing or telling people that you had a headache. And there are acute and persistent subforms of this. So acute is it's gone within 3 months after the injury, or else you aren't 3 months out. And then persistent is it's there for at least 3 months post-injury. And then we have this, it's not better accounted for by something else. So it's not because you have a bleed in your brain, for example, that you have this diagnosis. So I think this may help with some of these common questions. So you don't have to hit your head to have a concussion and have a headache that relates to it. Loss of consciousness also is not required for this. And that within 7 days of the injury or those other events around means that we don't typically think that concussion that's remote causes the persistent post-traumatic headache in the same way. We think that those kinds of injuries can sensitize the brain pain ways, but we don't call that the same kind of post-traumatic headache in that case. There is a category of headache attributed to whiplash, which is not well studied. You'll see as we go that the one that I'm going to be talking about is still not well studied, but this is even less well studied. This can be very disabling and hard to treat, and I'm not going to talk about it so much today. There are a lot of debates about whether post-traumatic headache is its own thing, or is this actually something like migraine that's a post-traumatic version of migraine? So is it masquerading as something else? And so both of these things could be true depending on the person. So somebody who has no headache before their injury, or someone who has a really different headache before their concussion, and we call this post-traumatic headache. But somebody who has a pre-existing version of headache that becomes worse or more frequent after the injury may actually have a component of this post-traumatic headache and a component of worsening of their other headache disorder, which is something that I tend to see a lot as a headache neurologist. We are working towards having some new criteria to diagnose this. There's a fourth version of our criteria in preparation, and we're hoping in the next couple of years it will come out. So stay tuned. So phenotyping this, so what does it look like? The ways in which headache after concussion looks tend to look like other types of things. So commonly it looks similar to what migraine looks like, or what tension type headache looks like, or sometimes other things that can look similar to cluster headache or cervicogenic headache, which is headache related to a neck problem. And actually migraine with aura is the most commonly reported thing headaches look like in people who've had a sports related acute injury. And so maybe this is what our patient is experiencing with that episode of the vision sparkles that he told you about. But most commonly, these headaches look similar to migraine or look similar to tension type headache. And always we want to look for these red flags that tell us there might be something else wrong that's going on to cause the headache problem that you're having. And we have these things that we snoop for, these signs that might tell us there's something else going on. So things like, do you also have a fever? Are you at risk of something else? Like, do you have a history of cancer? Do you have neurologic signs? Like, are you weak on half your body? Did the onset of the headache start really quickly? So go from nothing to 60 within less than a minute. We call that a thunderclap headache. Are you older? Or do you have something that's really different if you're over the age of 50? Or there's some keys. So was your previous headache really different? Is it precipitated? Can you bring it on by coughing? Or for example, having a bowel movement? And then is it positional? So is it really terrible when you stand up and goes away when you lie flat? Or is it really terrible when you lie flat and goes away when you're upright? These are all things that we look for. And if we hear these types of things, we get worried that there's something going on. But coming back to Ryan, when we meet him and we've asked all these things, he says it's a bilateral tension in his forehead. It's always there. It's worse when he concentrates, when he's trying to do schoolwork, looking at screens, or if he tries to exercise. And he tells you he's not sensitive to sound, he's not vomiting. So does this sound like tension-like headache? So I'll tell you that we normally look for borrowing the criteria from the other disorders to see what these things look like. These are a criteria for migraine. So you have repeated attacks of headache that have this 2+1 features. So 2 of one-sided, throbbing, worse with activity, moderate to severe, and 1 of nausea or vomiting, or sensitivity to both light and sound, photophobia and phonophobia. And so I'd like to point out that for these criteria, you could have 2 things that were, for example, worse with activity and moderate to severe. It doesn't have to be one-sided and doesn't have to throb, but it could still be in keeping with a migraine-like headache if you had these other features that were present. And so asking about the behavior, what people like to do during their worst attacks is helpful if you're not sure. So people may often think or say that they are not aware of light or sound sensitivity. But then if you ask what they want to do, they'll say, of course, I want to turn the light down. I want the room to be quiet. I don't want to listen to the radio. This is my dog burying her face under a pillow. Not sure that she has light sensitivity, but this is a thing that somebody might do. So getting back to Ryan, when you ask him about this stuff, he says that he's worse when he's moving around or exercising. The worst headaches are moderately severe and they slow him down. And he can't listen to loud bass in music anymore. And he actually had to turn down his screen brightness because he was feeling a lot worse looking at it. And on his very worst days, he doesn't have much of an appetite. And so that can actually indicate some low-level nausea. So actually, these headaches are migraine-like. So now what? How are we going to help Ryan with all of his studying and getting back to all the things that he wants to do? So just as a general thought, we don't have great evidence for how to treat post-traumatic headache, but there are some really nice guidelines that are online. The Living Concussion guidelines, the website is here, that are nice to read. They've got lots of details that you have potentially seen in other contexts before because they deal with headache and all of the many other kinds of symptoms that people can have after a concussion. And I do want to highlight that headache doesn't exist usually by itself. So I'm focusing on this, but it's a little artificial for me to talk about just headache and not the other kinds of things that are important to people who have concussions. In general, the evidence is not great. We don't have any really approved treatments for this. They're all off-label, but we tend to treat the phenotype. We treat the headache as what it looks closest to. So if it looks like migraine, we treat it very similarly to how we would treat migraine. We are starting to learn that if you treat people early, they often do better. We think that if you're stuck in a place where your pain system is turned on really actively for longer, it's easier for it to get stuck. And all systems are go, and it's very hard to turn down that light bulb. And so this is within weeks, ideally, starting to treat the headache. Treating it way too fast may mask some of those worry signs, those snoop signs that I mentioned, which could tell you that something else is going on. But in general, this is not something to necessarily ignore. And there was a very nice systematic review a couple of years ago that said there's a lack of high quality studies here. We need more studies. But there have actually been some of those in the last couple of years. And so this is one of the more recent reviews that was published in the end of 2023. Again, still we need a lot more research into what to do, but I'll tell you about some of the new options that had some studies, and we don't really know whether it's best to treat one way, combine multiple ways, or what. But in general, again, we target what it looks like, and then we look at multiple kinds of areas. So we look at lifestyle, there can be behavioral treatments, there might be vitamins that help, there are acute treatments, what do you take when you have a worse attack, and then prevention, how to keep things from being difficult in the first place. And the lifestyle stuff is often the pillar of this, and it's not that doing these things necessarily makes everybody all better, but these are the things that can make the pain system just more sensitive in general. It doesn't like changes inside, such as missing sleep or missing meals. And so what people can do to minimize those things, so consistent sleep, having breakfast protein in the morning within an hour of waking up, staying hydrated, not having too much caffeine, and then trying to exercise as tolerated. Green space actually has some studies in green light, but green space itself for being potentially helpful. And then trying to keep a headache diary. This one is really tough for many people with post-traumatic headache, especially if they have headache all the time. It's very hard to want to keep track of that. But this can be helpful to just guide in general. Are things getting better? Are things getting worse? Are there things that could be changed in the lifestyle or medications to try to help make things better? The behavioral kinds of things, again, these are sort of borrowed from migraine, but there are actually some studies specifically for post-traumatic headache for cognitive behavioral therapy. Mindfulness and meditation can be helpful and are potentially more easy to access. There are lots of apps and things like that that are easy to use at home. Cognitive behavioral therapy for insomnia specifically can be helpful. And then maybe things like progressive muscle relaxation or biofeedback do have some studies as well. And then these are the vitamins that are studied for migraine, but again, we borrow them for post-traumatic headache if it looks migraine-like. So vitamin B2, which is riboflavin, magnesium, which can also help with sleep, especially if it's taken at bedtime, coenzyme Q10. There's a thought that vitamin D actually may be important. And then melatonin, which is the sleep hormone, has some studies for headache prevention. It's actually in our migraine prevention guidelines now, not just for sleep. The acute treatment, this is what do you do when you have a bad attack? And ideally, you take a thing and you feel better within an hour or two without bad side effects. And this usually is more likely to be successful if you take something early, and side effects are actually less likely if taken early. And the things that we use for these migraine-like headaches are the triptan family, of which we have several, anti-inflammatories. There are these GPANTs oral CGRP antagonists that are some of our newer options. Maybe antiemetics like metoclopramide, and then there are a couple of devices. I don't have an affiliation with the company, so but I apologize for the brand name. It's an external trigeminal nerve stimulator, which is not lightly roll off the tongue. This is a thing that stimulates the two nerves coming from your eyebrows, that can be used for as needed or preventive treatment. And many of my patients with post-traumatic headache actually find this quite helpful. We do want to avoid medication overuse headache, or MOH, which we used to call rebound headache, which is something that's very easy for people who have headache after a concussion to develop, especially if they have a lot of headache a lot of the time. It's easy to end up in a place where you're reaching for medications a lot. And so this is something where people have headache at least half the month in the context of taking some of these medications too frequently for 3 months or more. There was a study in Denmark that said that almost half of people with post-traumatic headache who were referred to a headache specialist had this at the time of their referrals. This is a lot of people who end up in this place. It's a little different what is too much depending on the medication. So for triptans, it's about 10 days a month. For things like acetaminophen or ibuprofen, it's about half the month. Opioids, we tend to think can do this even just a couple days a month. And I'd like to highlight that your brain doesn't know why you're taking a medication. And so if you also have, let's say, back pain and are taking acetaminophen for that, it counts as a day that your brain saw the medication. And it also is true that the days are adding up between these options. And so unfortunately, rotating between them doesn't cut down on the number of days your brain sees a medication. We don't think that some of those other treatments, like the long-acting anti-inflammatories such as naproxen or those new gepants, cause this, but all the other ones can be concerning. And so when this happens, we often try to do multiple things. We try to help stop potentially the medication that's being taken much more than is helpful. Sometimes to do this, a longer acting anti-inflammatory or nerve blocks or something to help bridge that gap can be important. But in general, people get stuck in this place because they have a bad headache problem and they need help. And so something to prevent it from being so bad in the first place is important for many people who have medication overuse headache. When thinking about how to approach these attacks, this is a method developed by some of my colleagues at Women's College Hospital, thinking about the impact of attacks. Because for many people, especially who have many days of headache, some days are more impactful, but it may not always be the headache pain that's the worst thing. So maybe it's the light and screen sensitivity, or the brain fog, or the nausea. And so on a day where you have to stop because of the symptoms, you call it a red attack. On a day where you're slowed down, it's yellow. On a day where you can still go, it's green. And potentially you may need to combine more things for the worst days than for the less. And so you might only need one, for example, anti-inflammatory for a milder day, but you might actually need to do multiple things on one of the worst days. For prevention, we often want people to get at least half better in terms of how often and how severe headaches are. But unfortunately, we currently don't achieve that for everybody, especially in people who have daily pain. Trying to make things less severe and more manageable with less life impact may be more realistic, especially for people who've had these kinds of problems for longer, where the pain system is really, really turned on for years. It's much harder to make people have that 50% reduction. And when we're doing this, we usually start medications really low dose. We go slowly. We think about who you are in terms of choosing medication. So let's say you have had kidney stones. Some of our medications that have that as a potential side effect, like topiramate, would not be optimal. And we have always thought that it could be good to have a twofer. So if you also have mood symptoms and one of these headache problems, to take a mood family medication, but that doesn't always lead to the best choice of medication for either problem. And so it might actually be better to pick the best one for mood and the best one for headache and have two medications instead of a kind of meh choice for two at once. So in terms of things that we do, we often borrow them from other problems. We borrow from blood pressure or seizures or mood family medications. Then there's some other unusual ones and some targeted options. And I've highlighted here candesartan, which has recently made it into our migraine prevention guidelines, as well as things like beta blockers and the anti-epileptic family stuff like topiramate. Topiramate has quite a high side effect rate, including things like brain fog, which is a very common symptom for people who've had a concussion. So this may not be a great choice in terms of exacerbating some of those symptoms. The mood family, we often have things like amitriptyline or venlafaxine. There are some concerns about long-term impact of some of these medications, like amitriptyline potentially increasing risk of dementia. We're not entirely sure if the studies that showed that were confounded or if it's a true association, but it's worth potentially being cautious. Memantine is a dementia medication that's in our new guidelines and that I have found helpful with brain fog sometimes in my patients with migraine and post-traumatic headache. And then among the gepant family, we have atogepant for daily prevention. We also have some other kinds of things. So onabotulinum toxin A by the preamp protocol for people who have a chronic migraine-like headache. And then CGRP monoclonal antibodies, of which there are 4. There have been a couple of studies specifically in post-traumatic headache that haven't shown consistent benefits. Some of the studies showed benefit and some didn't. And so we're not sure, again, if these are a great choice for people who have headache after concussion or not. In my own patients, I've had some who found them very helpful and some who haven't. So they are potentially still worth trying. And then again, that Cephally device that I mentioned can be helpful here. For tension type looking headaches, we don't have as many options. We often use anti-inflammatories or acetaminophen. And then for prevention, things like those tricyclic antidepressants, such as amitriptyline or mirtazapine. venlafaxine, tizanidine, maybe gabapentin. In terms of what to do when you're on one of these things, it actually can be a very frustratingly slow time to see improvement. And so for the pills, it's often 2 to 3 months to know for sure if they're helping. For onabotulinum toxin A, it's to 3 rounds every 12 weeks, so that can take up to 9 months. And then for those monoclonal antibodies, it can be up to 6 months. And that's not to say that these don't work faster for some people, but we often give them at least this long before we decide whether they're helping enough or not. If they're not working after a reasonable amount of time, or if they're not tolerable, then stopping makes sense. If they're working a bit, often it actually makes sense to add something else in instead of losing the bit of benefit that you had, and then maybe take that first medication off in future once things are hopefully better. If things are going well, ideally we want people to keep doing well and stay doing well for long enough that their pain system relearns how to look at the world until they stay well for a good 3 to 12 months before trying to come off those medications. And sometimes that's successful and sometimes it isn't. And potentially people need to stay longer and maybe try again down the road if things are getting worse when they try to stop. And so for Ryan, we have done some things. We collaborated. We've given a multimodal treatment plan, put him on candesartan, which is the oral agent that I most commonly use if I'm choosing something like a daily non-targeted pill. It has pretty good evidence for migraine and a lower side effect rate than some of our other options. And within about 3 months, actually, he thinks things are starting to feel better. He's able to carry his course load a bit better, still having some of those headache attacks every few weeks, but those are responding to his acute treatments. And this is something that people do certainly notice. This is not somebody who previously had bothersome headaches or headache attacks, and now they're happening, and it looks closer to what would happen for somebody who had migraine. And so we may need to continue those migraine kind of treatments on an ongoing basis, especially the as needed ones. But his dream of going to med school is back on track. And so just a couple of things that I want to highlight before we have our discussion. So headache is really common and can be really disabling in people who've had a concussion. And it most commonly looks similar to migraine or looks similar to tension type headache. We do want to hopefully start treatment reasonably early to try to keep people from getting stuck in a worse pain pathway and avoid things that may keep people in worse headaches, such as medication overuse. And to do this, we often treat based on what the headache looks like, which again is probably borrowing some of the migraine or the tension evidence, since we don't have really great evidence for how to target post-traumatic headache itself, outside of a couple of those things that I mentioned, for example, cognitive behavioral therapy, and then maybe a couple of the medications. And so I'm hoping that we'll have a good discussion, that you'll have some good questions for us to go over.
Great. Thank you so much, Dr. Sandoe. Oh, okay. There we go. That was an excellent presentation, and we do indeed have questions. The first one is from Dr. Cobley, and she's asking, I've heard that light sensitivity and noise sensitivity can be symptoms of migraines, even without the headaches, and such can be treated with migraine medication. And she's just wondering what your thoughts are.
That's an interesting question. So people who live with migraine very commonly have those types of symptoms even outside their headache attacks. So they might be somebody who never really can tolerate bright sunlight and always wears the sunglasses, or fluorescent lights are always tough, or can't stand to go to loud concerts. And that is probably a reflection of the fact that that person's brain is just a more sensitive brain in general. And so if this person has that and never has any headache, I think it's hard to say they have migraine, because we have criteria that say you have to have a headache of some type at some point. But I very commonly see those types of symptoms between attacks, especially in my patients who are having more and more headache. Their brains are closer to that attack threshold for their migraine attacks. And so if you are able to do something to prevent migraine and reduce the overall sensitivity, you may help reduce those. They don't necessarily go away for everyone. People living with migraines, brains are just wired a bit differently. This is part of my bio about a more migraine friendly world, actually, because I think that it's not put together for people who have these things, who find smells triggering or fluorescent lights tough. This is what many of our work environments just look like, or who, you're at a conference and you're not supposed to have a lunch break. These are things that are very tough for most people with headache disorders. The world is not intended for that.
Excellent. Thanks so much. Uh, Lena is asking, can you elaborate more on the green space time that you referred to?
Yeah, so the studies here are not huge because it's a kind of harder one to study or get funding for. But there's a suggestion that time in green space has a lot of health benefits for things like reducing heart rate and reducing cortisol and decreasing stress levels. And there's some studies, small ones, specifically about migraine. I'm hoping we're going to have better ones. But this is also something about the concept of, for example, forest bathing, where people go out into the green space in particular, things like forests that are not necessarily just the green, but it's probably something also about the natural environment that's helpful. So being out in nature, there are programs designed to help people promote this. For example, there's the Park Part RX, where doctors can prescribe passes to parks for their patients to try to help them increase their ability to access green spaces that are interesting to know about. And I don't think we talk about necessarily as much how beneficial it is to not be in concrete with the hum of electricity and things all the time and have some green and growing things.
Excellent. Thank you. Someone is saying naproxen long lasting, meaning how long?
So I think the half-life of naproxen, I think, is somewhere in the like 12 to 15-hour range. Um, it is more long-lasting than some things like indomethacin that are only a couple of hours. And so naproxen and ibumethone are both sort of 8, 12, 15-hour half-life, which means it takes your body, they're in your system for longer before your body breaks them down. Those ones, there's a bit of debate here. We don't fully understand why or why not, but we don't think that those ones end up leading to the medication overuse risk in the same way that the shorter ones, such as ibuprofen, probably do.
Okay, great. Thank you. I've had daily headaches for 5 years. I've tried candesartan, amitriptyline, gabapentin, vision therapy, and nothing has worked. I was told Botox may be the only other option. Is there anything else I can try?
Yeah, so I think this depends a little bit on, and obviously I can't give individual health advice, but I'm happy to answer this general question. And this is to part of the point that I was making, that headaches after concussion can be really long lasting and really disabling, and people's pain systems can get really stuck and it's hard to work against them. So things like Botox, autobotulinum toxin can be something to consider. We do also, if it looks like migraine, borrow all of those other migraine things that I mentioned. So the CGRP targeted treatments like the monoclonal antibodies for the prevention GPANT. And that's something often worth considering if the headaches look similar to migraine. If they don't, we don't have a lot of studies to say that they might help or not. But I think that it's a really frustrating process for people to not know in advance whether something that they take is going to help. And so it's often very slow and very frustrating. But I think we do end up helping more people than not. It's not necessarily one medication that's the answer, though. I think it's putting together all of these things. So the lifestyle, considering the cognitive behavioral therapy, considering the medications, all of this stuff working together to desensitize the pain system and help walk off of that path that people get stuck on.
Excellent. Thank you. Next question is, does gabapentin, using it long term, contribute to dementia?
That's a good question. And this is an area where there's some debate and concern. So there are some studies that suggest, especially in older individuals who are using gabapentin for longer, there is this concern for risk. We don't really know how long or how old or what dose exactly is worrisome. And the other, I don't think that we have a conclusive answer to this. There are some studies that say potentially yes, and then there's some that say we're not sure. It isn't necessarily benign to just live with a bunch of headaches either, and all of the symptoms and life impact that can come with that. And I think that sometimes when people are stuck with really disabling headache disorders, their lives become very restricted and their social life and all of that really suffers. And those things are risk factors for dementia as well. And so it's not necessarily benign to be at home with a headache, not on gabapentin. And so that's not to say that it's not risky, but there are risks and benefits to be weighed about having those pieces of life.
Hmm. Yeah, great advice. I'm just going to comment. I think that there's been a couple of questions, maybe for people that signed on late. Just so you know, you can access the videos on the Canadian Concussion Center website. Christian had posted the link in the chat. So you're able to usually see that about a week after the presentation. Joseph is asking, what was Ryan's multimodal treatment plan?
So I kept it vague because you'd probably tailor this to the individual person, but I think we would go over all of those different areas of pillars. So we would try to make sure that lifestyle was on track and there wasn't excessive phone use right at bedtime, and that the screens had a good refresh rate and a blue light filter, and that maybe there was a reduced course load while Ryan was trying to get back into work. And we'd make sure that Ryan was doing all of the meditation at least 5 minutes a day. I'd probably consider, because those headaches look like migraine, the vitamins that I mentioned, in particular things like magnesium, vitamin B2. And then for the acute treatment, we could pick anything we wanted. I think something like a triptan is often a good, effective starting one, or potentially an anti-inflammatory. And then we mentioned the candesartan for prevention. And I also usually offer the Cephaly device to anybody who I think might benefit from it, which is most people, unless you have a lot of sensitivity to touch or a reason that it wouldn't be safe, like a pacemaker or another implanted device. It's a relatively non-harmful option to consider trying, although it can be expensive. Sometimes insurance covers it like a TENS unit. And so it would be all of those things put together. It is sometimes tough, especially for younger patients, to do all of those things. It's very difficult to go from being somebody who was healthy and who had a specific vision of themselves in the world and their future, to somebody who now has this medical condition and a whole bunch of impact in a whole bunch of domains. And sometimes I find for my younger patients, it's very hard for them to be able to put all of those pieces together. So this is going to take you talking to that patient and helping support them through building this into their lives and normalizing the fact that it's hard. And they are probably not going to come back just with the world's most perfect lifestyle. It's probably going to take some work to try to change the way that they're seeing who they are as a person while they're hopefully getting better.
Great, thank you. Someone else is asking, could the whiplash be part of the whole concussion related issue? And therefore, does that need treatment?
This is a tough one because, as I mentioned earlier in the presentation, whiplash related headache is not very well studied, and there's probably some overlap with a cervicogenic type of headache, which is headache related to a problem with your neck. And so it's common for people to have weakness of neck muscles and maybe some compensatory posture changes and things like this after head injury. It's common to have a component of whiplash. It's not something that I, as a headache neurologist, necessarily target as much. That's something that it's always worth for anybody with any headache disorder, trying to get all of your ducks in a row about making sure that you are as healthy as possible, which may include things like physiotherapy to strengthen the neck, because having pain elsewhere in your body makes your pain system more active. And so even if the neck thing itself isn't directly causing some of the other headache issues, it's probably feeding into them. And so absolutely agree that addressing it can be an important thing. It's just not as directly included in our PTH criteria or those sort of targeting what the headache looks like plans.
Great, thank you. Paul is asking, can you comment on magnesium citrate versus bisglycinate? And can you provide any further information about non-pharmacological strategies, things like using cold packs, heat packs, neck massage, that kind of thing?
Mhm. So for migraine in general, we commonly suggest magnesium citrate just because there are a few more studies about it. Your body absorbs it a little bit better, which also means that there may be more side effects like diarrhea, which can be not tolerable for some people. So commonly I'll suggest that people take the citrate form, but if that doesn't work out, then try something like bisglycinate that has maybe that lower side effect profile. There's some other versions. People even sometimes end up with things like topical magnesium, which may not be absorbed very well. The non-pharmacological stuff, and again, this is not based on really good studies, and I'm not sure that there is a specific one size fits all answer to should it be hot, should it be cold, should it be neck massage, should it not. I think those are sometimes things that is worth experimenting with. They're unlikely to be harmful. There are, for example, various cold devices that people can get, helmets that have modular ice and things that you can move around, so that if you have more pain in the one side than the other, you can move more of the ice to that, for example, that some of my patients find quite helpful. And then like I was mentioning about the neck piece, I think keeping the neck strong and happy is helpful. I think physiotherapy is probably a better long-term way of doing that than something like massage that might provide more temporary help, but not help with weakened muscles or poor posture or those kinds of things. And then there are other, sometimes people like topical creams and those kinds of things, which I think have a big role, but again, they don't have lots of studies and there's probably more individual experimentation with those. The other thing sometimes people find helpful that's not a medication is the tinted glasses that help reduce some of the screen sensitivity, the FL41 lenses. And there are a couple of companies that make those. They can be expensive. Or fishermen's glasses have a similar kind of tint to them. So sometimes people will try that to reduce some of how triggering the lights can be to feeling worse.
Great, thank you. Um, Someone is asking, can you clarify? You indicated acute management is tailored to the symptoms profile and not just the headache. They're wanting you to clarify. I don't know whether they're talking about symptoms more generally of the concussion
Okay.
or.
I'm not sure either. I think for most of our headache treatments, we pick based on what the headache looks like. So does it
Mhm.
look like migraine? We often use those migraine treatments, which might be triptans. Does it look like tension type? We might be more likely to use the anti-inflammatories.
Okay, great, thank you. Is there a reason why when I just even brush the top of my head, not hit it, my daily post-concussion headaches can become far worse?
This is a tough one for people who've had especially multiple head injuries. There's often concern about getting worse and worse and worse. And I think there are a couple of different things going on there. There may be mild re-injury, but the other thing that can happen is that it can be extremely anxiety provoking to have these things happen and know that previous injuries caused all of those symptoms. And so there can be this experience of anytime something happens, people end up in a place where they think that everything is going to go off the rails and all the progress they've made is going to be lost. And that stress can really drive symptoms, not cause them, but it drives and magnifies everything that people are feeling. And sometimes strategies to say, okay, this was a light hit. I'm continuing to improve. I'm going to get through this are really important to help dampen down those feelings. And I'm not negating the experience of having worse pain after this, but that can really drive some of the experience around it. I'm sure this is something that you may see in your practice, Dr.
Mhm.
Ratan.
Yeah, yeah, absolutely. That can certainly be a component. Christian is asking how to treat cervicogenic headache with a patient who has success with a Jovi.
So I guess is the question, do they need something else or is the AJOVI working well? Um,
Yeah, I'm just looking to see. I think she added, yet also has diagnosis of cervicogenic headache.
um, so cervicogenic headache is a kind of controversial diagnosis, and I'm not sure that it's always applied in a way that we in the headache world would apply it. I think so. Cervicogenic headache, by our headache criteria, is supposed to be a very specific thing that's caused by an identifiable problem in your neck, for example, a pinched nerve, or rarely something like a muscle issue. It doesn't mean just pain in your neck, which is a common feature of whiplash. It's also a common feature of migraine that at least half of people with migraine have a lot of neck pain. And so the term itself may not be applied in the same way in different people. So I would probably start by taking a step back and saying, do we think that there is actually a separate specific neck thing that's causing headache, or is there this, your brain pain pathways are turned on, as happens with, for example, the migraine-like ones, when you can have neck pain in consequence. AJOVI and those CGRP monoclonal antibodies are not really studied for things like cervicogenic headache, and they work on the chemical CGRP, which is one of the important pain system chemicals in general, but they're less likely to help those conditions that are caused by a structural neck thing. And so if the Jovi is working well, I'm not sure that it would need a specific target. If you have good benefit from one thing and then you still have another problem, then reassessing and targeting the other problem is always a good idea. And I think for cervicogenic headache in general, it's helpful to start with things like trying to get the neck as strong and in good posture and everything as you can with physiotherapy. So neck strengthening physiotherapy. And then we sometimes use things that target nerve pain, like the anti-epileptic family or those tricyclic antidepressants. And then depending on what's found as a problem, for example, if there is a specific nerve that's being pinched, sometimes nerve blocks to that area, often guided by imaging or ablating those nerves can be a helpful thing. But typically we start with the less invasive stuff first.
Great, thank you. Does too much blue light from computer screen use cause headache?
Some people are very sensitive to the blue light from screens. People with migraine, people with concussion. Blue light is not great for your sleep hormone pathway. It's just not what our eyes were intended to see. So in general, the idea is that reducing it may be helpful. I have to say the blue light filters that come on computers or that you can get for screens help some people, but not everybody with this issue. They're probably worth trying. They're a pretty benign thing to try if you can.
Great, thank you. What about low oxygen from high altitude? Does that contribute to headaches?
So people are very sensitive to altitude changes. I have some patients with migraine who go off on mountaineering expeditions and have a terrible time while they're there. Or people can get headaches caused by probably altitude changes when they're going up and down for flying in some cases. And it's not clear if it's something about altitude change or oxygen levels or what. It's plausible that there could be an oxygen contribution there. But for those types of things, the treatments that we use don't necessarily target oxygen. So I'm not sure that we know but this is possible.
Great, thank you. And what do you think of the advice to push through the pain somewhat to get back to activities of daily living?
Yeah, this is a tough thing. I think it's tough to tell yourself to do it and feel like you're making yourself worse. And it's also very against what we used to tell people, which was wait until you're better and don't make it worse. There is the idea, though, that your brain learns to live with what it has. And so we see this for headache, or we see it with vestibular symptoms, for example, that if you are living in a world of reduced movement, reduced light, your brain has a really hard time when you're in a place of increased movement, increased light, those things. And you can't let your brain stop being able to react to the world, or it can learn over time that it's just not going to do that anymore. And so having a bit of impact and potentially a bit of pain is not necessarily harmful, but at the same time, if you are having more pain, your pain system is often more easily activated next time. And so I don't think that pushing through for a long time and making yourself feel terrible is a great idea. But pushing a little bit against those boundaries, whether it's for pain or any of the other symptoms, can be an important thing.
Great, thank you. Someone is asking, how do we get these medicines, basically? How do we get these prescriptions? Our specialist wants to keep trying only one drug, amitriptyline, at higher
Mm.
doses over several months.
So it could be helpful to take to your doctor. You can even find their Migraine Canada, American Migraine Foundation, some places have suggested ideas. You can always take some suggestions to your doctor, say, I read about this, can we talk about it? I think the way in which we treat any headache disorder, migraine, post-traumatic headache, what have you, has changed dramatically over the last little while. And sometimes people have had really good success with something in the past. And so that's what they hope will be successful for everybody in future. And every patient is different. So I don't think that it's harmful to tell your doctor, I heard about this thing. Is this something that would be appropriate for me? And sometimes backing it up with those resources can be helpful. There's the Canadian Headache Society that has some really good guidelines as well that people can be directed to read about these. Those living concussion guidelines that I mentioned as well, specifically for post-traumatic headache, have some good suggestions about other medications and doses and things like this to try. If you're really getting nowhere, you can always ask if seeing a different specialist would be worthwhile. But if you have a good relationship with someone, I think doctors want to help their patients feel better. And if that includes a discussion about different things that you're interested in trying, that sounds worthwhile.
Great. Yep. Thank you. The next one, they're saying, so this is more about the on the non-pharmacological side using the
Mm.
vitamin supplements. So my husband took the B2, the magnesium, coenzyme Q, as recommended by a neurologist for his migraine, but his headaches got even worse. We have no idea why. Then, when he stopped taking them, the headaches went back to normal. He was told that perhaps he was imagining the pain. increase, but we're positive that it occurred while he was taking them. So the question is, do these vitamins help everyone? And what does it mean if they hurt? Could they be taken incorrectly?
Interesting question. So, unfortunately, none of our options help everyone. And some of them have paradoxical reactions. So, you expect it to help and it hurts, for example. I think that can happen for everything. It's not common for vitamins. The thing that I have seen is that sometimes people have a form of a vitamin that has a dye or an additive or something that they're sensitive to for red ones or yellow ones. And I've seen that that can be the case. The B2 often has yellow dye in it that some people are just sensitive to. And so it's sometimes worth considering trying the things one at a time and seeing if it really is everything makes you feel worse or not. And it is, I am hopeful that at some point we will be able to know in advance which of these things are right for which people. But currently we're in the place where we say the balance of evidence is that more people than not will find this helpful. It's worth a try.
Great. Yeah. Thank you. Who should receive Botox for concussion headaches?
Good question. So I think that this is most likely to help people who have those migraine looking headaches. Botox is studied and approved for chronic migraine. And so it really technically is off label for post traumatic headache. And if we're using it, we're saying we think this headache looks close enough to migraine that it's probably going to be helpful. The way that it works, we think, is actually on the sensing nerves, the small little nerve endings around your head and shoulders. And it tries to decrease the amount of activity that those nerves have so that the amount of information the inside of your brain receives is less. And so it's trying to dial down the inner brain activity by quieting down the outside. And so that doesn't necessarily help people who have the tension looking headache, and it doesn't necessarily help everybody with the migraine looking headache. But I would give it a shot in a literal shot in somebody who had the migraine looking headaches and thought that that was something they wanted to try. I also think it can be quite helpful for people who have aura, and people who have reasons that they can't try other things. In particular, this is a great option because it doesn't get absorbed by the body, doesn't interact with medications. It's a safe one for people with other health conditions in many cases.
Excellent. Thanks so much. We've got so many questions tonight. Joseph is asking, since photophobia is a common symptom of concussion, among others, what is your viewpoint on using pupillometry to quantify pupillary constriction and dilation rates, among others, to determine frontal lobe function as well as the function of the sympathetic and parasympathetic nervous system? Depending on these findings, how would you approach returning balance in these systems?
I don't have, unfortunately, a very good answer at all to this. I don't know that we have great evidence here from the neurology perspective. And the autonomic nervous system function is obviously a hot topic, but I don't think that we have great studies from the neurology perspective on this. I'm sorry, I don't have a good answer to that question.
Okay, no problem. What is happening when alcohol causes headache at the site of a past concussion? So I'm assuming when a person drinks alcohol, they're getting
Mm.
recurrent
So it's
pain.
possible that alcohol is an attack trigger for headaches for some people, and so perhaps that is a sensitive part of the brain where pain is felt in times of things that might trigger. For some people, there are just triggers like that, like alcohol can be one, or smelling smoke, or eating cured meats. And so my hypothesis would be that that part of the pain system is sensitized by what happened to it.
Okay,
The other
excellent.
thing to say, though, you can have cluster-like headaches after a head injury, and alcohol is a big trigger for cluster kind of attacks. And so that would be a different looking headache, probably.
Okay, thank you. Krista is asking, what are your thoughts on the use of cannabis products for headache prevention or treatment? She says, I assume not enough evidence yet.
Yeah, not enough evidence yet. It's being studied. There was a small study about trying to use this acutely for migraine. We don't have really good studies for other disorders. There are, however, some studies in mice that suggest that cannabis over the long term can increase the risk of the mice having what looks like the medication overuse headache phenotype. So their pain systems actually get sensitized. And so we're not quite sure what this means in humans, but there is some concern that actually using cannabis regularly over the longer term might make things worse headache wise. I'm hoping that we're going to have better targeted studies on this in the near future.
Excellent. What is your thought on neuromyofascial release on symptom relief for headache?
This is another one where I don't have really great knowledge about
Hmm.
the answer to that question. I'm sorry.
Okay, no worries. What about acupuncture? They're asking, does
So
that work for?
yeah, so acupuncture is another one of those things that we borrow in people who have headache that looks like migraine. There is some evidence for migraine, not as much for other headache disorders. In general, I think the risks and the side effects of acupuncture are reasonably low. It's got a cost for many people, but it's one of those things that is not as well studied. So I would probably start with other things. However, it's not as likely to be harmful and can help some people. So if it's accessible, to me, it's kind of like a why not worth trying.
Great, thank you. Is it reasonable to suggest that the vitamins, or to suggest vitamins to everyone with post-traumatic headache? Are there side effects to be aware of?
So with these also is a lower risk option to try to build in. And I'm not sure that they are the answer to the problem for most people, but they may be helpful with a lower risk. I probably again would be more likely to suggest them for people who have headaches that look closer to migraine, because then we assume that they're more likely to help. All of them have risks, although they're lower risks than medications. So vitamin B2 makes your pee yellow, and it can give some sort of increased frequency of peeing or discomfort, rarely, especially in men. Magnesium can give diarrhea. Coenzyme Q10 in higher doses is not necessarily great for you, but in the lower doses that we use often doesn't have so much side effects. And vitamin D in reasonable doses is probably good for everyone in Canada to take anyway. Um, Melatonin, which isn't really a vitamin, but was on my list there, doesn't have a high side effect rate either. Sometimes people can have sleepiness or vivid dreams, this kind of thing. So again, I think they're worth considering because all of this is a choice about is it likely to help versus give a side effect, and the side effect rate is low. These things can be costly though, and most insurance doesn't pay for them, so that can be limiting for some people.
Great, thank you. Can TMJ pain contribute to post-traumatic headaches? And if so, what can you do?
So I think this is anything that gives you other pain can contribute to worse headache. And having a component of a TMJ problem can certainly make people worse. I don't commonly see it as the only thing that people have, but absolutely can make people worse. And the TMJ kind of targeted treatments, I think, are often best in the hands of specialized dentists or massage therapists who are able to, or even physiotherapists sometimes who are able to try to help realign or strengthen as necessary, or sometimes use medications or toxin injections or those things if the jaw really, really has a problem. Some of my patients do have a bit of TMJ stuff on top, and so sometimes we might off-label use a bit of onabotulinum toxin in the jaw in those cases. Again, that's not a really well-studied thing to do. And specialized face pain or dentist is probably more expert in that than I am.
Okay, great. We just had a request to repeat the name of the tinted glasses. Is
Oh,
that
sorry.
the
So
FL?
FL41.
Okay,
F
thank
is
you.
in fish, L is in lens, 41.
Great. Do primary care practitioners feel comfortable prescribing drugs like Ajovy without consulting with a headache neurologist?
So we're seeing a shift. These are still newer medications. We had the first member of that family in 2019. And so there's not something that everybody, especially people who've been in practice longer, necessarily learned to use yet. Some family doctors are comfortable, and some aren't. And the other barrier is sometimes that insurance wants you to have a prescriber who is some kind of specialist to access them. But typically, there's not a specific reason that a family doctor can't. It may just be something that because family doctors have so many things on their plates and so many types of medications and things to do, it may not be something that they feel as expert in managing. Um, but they could if that was something that they developed expertise in.
Great, thank you. Long drives can increase my headache symptoms. Why might this be?
So many people who have migraine like headache or who live with migraine or have that background have motion sickness as one of these childhood migraine equivalents, which is one of the things that you also have that indicates higher genetic risk of migraine. And often that can make people feel more nauseated or have more headaches. Sometimes there are things like the environment is hot, but I think it's often there might be a motion sickness element or a vestibular piece in there that contributes.
Great, thank you. I'm just aware of the time. Okay, I'm going to ask one more question and then we'll finish it off. Can using hyperbaric chambers work for post-traumatic headache?
So this is another area where we don't have really good evidence. I know this is something that some of the concussion targeted clinics will do. I don't think we have good studies there, and it's not something that in the systematic reviews came out as having enough evidence to be recommended yet. But we need more study for all of these things for post-traumatic headache, and what helps one individual may be different than what helps another person.
Great. Thank you so much. Okay, I think, yeah, we are at time. Thank you so much, Dr. Sandoe, for a really excellent presentation and question period. I just want to let everyone know that we will be back in 2 weeks on October 28th. We're going to have Shalene Solway and Elizabeth Crawford here talking about managing symptoms of dizziness and imbalance post-concussion. And just a reminder too that you will see a very short survey coming your way. If you have a minute or two, we would love to hear from you. We just, like to hear any suggestions or feedback that you have. Also, I apologize tonight. I couldn't get to everyone's questions. We had a lot. So if there are any burning questions remaining, you can always include those in the feedback on the survey as well as your contact info, and we can try to get back to you that way. So thanks so much and have a great night.